Hi, good afternoon, everybody, and welcome to CAF's COVID Weekly Roundup. Today is April 17th, 2020. We're going to be covering issues that have come across CAF's desk this week in terms of AFLs, issues with staffing challenges, and we got cruise ships on there, but not the cruise ship you're thinking of. We're going to talk about the Mercy ship a little bit down in Southern California as well. So I know it's been a super challenging week. I'm going to try to address the AFLs that came out this week, including one that came out last night that caused all of us at CAF a ton of consternation because it flies a bit in the face of previous AFLs that were sent out. So we'll cover the discrepancies there and kind of what CAF is going to do to try to correct the issues. So unfortunately, I don't have a guest speaker this week, but next week we will have a guest speaker. We had originally submitted a number of 1135 waivers to the federal government for broad approval of waivers of certain requirements of participation that were not met on the first go round with our 1135 waivers. We have yet to receive a denial or approval on the additional asks. But some of those things had to do with other stuff that we don't really, maybe it's not foremost on our minds. Things like life safety code and emergency preparedness and all of the inspection and testing requirements that require outside vendors to be into the building or to come into the building are no longer allowed. So how do we expand the time frame and get approval so that if we're not able to meet those requirements? We're working on that. I've got a guest speaker for next week who's going to come speak about how what are strategies that you can do to avoid getting cited, next time when you get your survey, if we're not going to get these 1135 waivers. So that stay tuned for that. That will be on next week's program. Today, I'll kind of cover our daily advocacy to the Department of Public Health and Health and Human Services, the EMS agency, and the governor's office. We have frequent daily communications with all of the above. We are also actively coordinating with the Hospital Association to determine best practices for alternate care sites. And CAF has been pretty vocal about asking alternate care sites to be the primary destination of COVID positive people since February. We testified in front of the legislature to that fact and have pretty much consistently asked CDPH to prioritize that. In the last couple of weeks, we've seen movement on this in the realization that the post-acute care of these COVID positive people presents a very large challenge for the current healthcare infrastructure because of the exponential risk by putting these folks into buildings that do not currently have COVID positive patients in it. There's a lot of work that goes on on our part by letting each one of these entities and government agencies know just how difficult it is to maintain infection control in healthcare environments. And it's not just skilled nursing facilities. There's a number of studies that have been done on all healthcare, hundreds and thousands of healthcare employees, catching this virus, even though they have been fully protected with PPE. So we can't say it's just an error on the part of the staff members or the administration of a building, because it happens over and over and over again at a magnitude that's cannot be explained by simple errors in donning and doffing PPE. So we know, and it's up, and we spend most of our day trying to convince public health and health and human services that everybody is doing everything humanly possible to protect the residents that are currently in our building. We have the state and certain local jurisdictions have opened up or have plans to open up 7 what they call alternate care site SNFs throughout the state. Now, some of them are located in areas in which There are acute needs. There's a facility in Riverside that is already open and taking COVID positive patients, and that's going to be a COVID positive only building. There are some other sites that are in non-skilled nursing buildings, but they're going to provide skilled nursing care. Arco Arena has been set up, and it's should be ready to accept patients, I believe, on April 20th. They did the site walkthrough, but that is going to serve both acute needs and post-acute needs. So they will have a section for COVID positive people that need a skilled nursing level of care to be provided at the alternate care sites. And we know that San Mateo has an agreement with a number of facilities to perform a similar service. We have not got indication of how San Mateo set that up, and we're actively trying to get a model from San Mateo to see if it could be applied broadly across different county jurisdictions. With this being managed by per county, we have a lot of counties with different or conflicting guidance, or when they're going to send folks to skilled nursing facilities. If you're in areas in the Bay Area or Southern California, more than likely you're under intense pressure to take these folks. And we've been in contact with the counties, and we know that not everybody, but a significant portion of the providers are refusing to take admissions. I don't know what to tell you about that. These are your businesses to run. But if you're going to take COVID positive people, there's a definitive way to do it as safely as possible. And any deviation from that is going to potentially put the folks at risk that are currently in our buildings. So those are all the things that we work on a daily basis, is working with the 61 different health departments and talking about SNFs and trying to get them from forcibly putting COVID positive patients into buildings. There are a number of local jurisdictions that have a very acrimonious relationship with their skilled nursing providers right now, simply because there's a backup in the hospitals. So hopefully you guys are taking this opportunity to build a relationship with the local public health department, to work in conjunction with them so that they can see the needs and limitations that you have in providing care for these people and protecting the current residents from the COVID positive residents. A number of counties are, as a best practice, have assigned public health nurses to take that checklist that CDPH has developed to go out on site to determine capacity and the ability to do that. And the results are kind of all over the board. A lot of local health departments have said, thank you, we appreciate you raising your hand and offering to help. But some of the people that have raised their hands with an offer to help may not be as prepared as they think they are. So to the extent you can, take a good look. If you plan on taking these folks up and being a placement source for COVID positive patients, really work with your local health department to determine whether you are accurately assessing your ability to care for these folks. I also think, I don't know if it I'm not an attorney, but I don't know if it protects you from legal liability down the road, but certainly it would help to have somebody co-sign that they thought you were capable of providing these types of services. And then we've been working pretty closely with IMSA from a state level. And we do know multiple counties have gotten permission to use EMTs as for staffing needs. So EMTs could be used in certain counties. So now, right now, the counties have had to send a request to the state for the approval for the EMS worker or EMTs to be in skilled nursing facilities. I know that in Alameda, Contra Costa, Santa Clara, Sacramento, San Mateo, and there may be a few others that have authorized EMTs to be able to do that. I'm trying to get confirmation that this will work across the state so the counties don't have to do that. We were told that EMSA was going to come out with guidance. That's the EMS agency that oversees all EMTs in California. They're supposed to send out guidance to the counties on how they can use EMTs to support staffing in skilled nursing facilities. So the ongoing PPE shortage and conservation of existing stock is still an issue. CDPH issued one of the best AFLs I've seen that they've issued in terms of optimizing the use of PPE. And it really goes into a breakdown of like a decision-making tree, like if you can't get this, this is the next best thing. And if you've not downloaded that and kept that for your records, I suggest you do it because it will help you in determining how you assign PPE based on the level of care that the healthcare worker is providing, and then options for what to do when each level of PPE cannot be equipped or purchased or obtained through other sources. So I think for our purposes is really good because it helps us kind of weed through pages and pages of CDC documentation to determine what's the best way to do this. I'm not a workforce person, but certainly if you guys are interested in having a more lengthy discussion on the use of, nursing assistant training programs, NAs, expansion of the scope of NAs, what EMTs can do, and all that, I think I would have to defer that to Claire Enright, the director of QAF, who also leads our workforce response to COVID-19. If you guys are interested in learning more about, different staffing strategies outside of the emergency response function, I can have Claire come on maybe on one of these webinars and we can talk about that, or maybe we can have our own webinar about that. And then most of you guys know this, but there are nationwide calls from SNFs to be treated the same as hospitals. And we're seeing, gosh, you guys probably see the news as much as I do, but SNFs have been really vilified over the response to COVID, and CAF's obviously very, very concerned that we think this is inappropriate, and it seems like we just are the target of folks' displeasure with how this is being managed by the state and by local counties. Unfortunately, we have to be reactionary to the guidance that the counties put out. And there are countless letters from all kinds of academics all over the state being sent to the governor's office asking that this be a priority. And I think for the first time, we've got some real traction in terms of supplying and resourcing and getting testing to each one of these buildings. I expect a lot more focus to be on us in the coming weeks, not that it wasn't already, the light wasn't already bright enough on us. And CAF will do their best to issue press releases and directly advocate to those government agencies to let them know that we should be celebrating our skilled nursing providers and lifting them up and celebrating the successes that we're having. Because what the papers don't say is there are a number of nursing homes in the state of California that have a COVID positive person that was transferred from an acute care hospital without being tested, and they kept and contained that virus to one person. And those aren't being celebrated. We hear about the handful of large outbreaks, but I don't think that has anything to do with infection control. It has to do with we don't have a capability of stopping this, not in a hospital, not in a nursing home, not in any congregate setting, until we fully mask everybody in facility. And that hasn't been a requirement or a recommendation up until just recently. So we have these large outbreaks that have happened through no fault of the provider at all. And it just, it makes us all upset that we see that the good work that you guys are doing is not supported at a state level. And so much of what we do every week is to get in front of legislators and get in front of their staffs to let them know what the press is not reporting on. All right, so I think I've covered this area, but I just want to, and I've said this before, I realized that folks do not have massive supplies of PPE. At this point, if you have not expanded your vendor network into other sources where you can purchase supplies from reliably, and you're not getting supplies through the MOAC process, email myself or Courtney. We have a list that we have put together of unvetted resources that sell PPE. We can't guarantee that these folks are, I could just say we've never purchased from them. But what is happening in many counties, including Los Angeles County, which is a third of the state, they don't have the ability to vet these folks either. They try the best that they can, but they've developed a list of vendors that are selling some supplies. And so if you're interested in that list, I'd be happy to provide it to you, but I cannot guarantee any of that. And there's language from LA County and most of the counties that are passing things like this out that says they can't verify that it complies with the FDA requirements and stuff like that. But if that is the only option you have and you cannot source it anywhere else, that may be your next source of PPE. All right. And all of this stuff that is, these bullet points are listed under the AFL for that 2039 AFL. And the last part is temporarily suspend annual fit testing requirements. That's per the guidance from OSHA. But I will say that there's a reason why we do fit testing is as a prevention or making the mask as effective as possible. If it doesn't have a proper seal, it reduces the effectiveness because the mask is supposed to provide all of the filtering for the air that comes in. If you haven't fit tested your staff, in my estimation, there are a number of really good short videos on YouTube. You can go onto the CDC website and just type in donning and doffing or fit testing. And you know, if you don't have anybody qualified to do fit testing, have your staff try to do it themselves. I mean, if it's me and I'm putting on an N95 mask, it's not that difficult to determine if you have a good seal. But you can't call it a fit test if the person hasn't been qualified to do the fit testing, and you can't really call it a fit test if you've not verified that they're medically capable of wearing an N95 respirator. So those things go into normal fit testing that we cannot do, or more than likely we cannot do now. And so in that case, I would have my staff watch those donning and doffing videos. Maybe have your DSD make it a part of an in-service for every single employee that you have coming into the building. So, and of course, there's guidance for the use of respirators beyond the manufacturer's designated shelf life. We're already using those. We're going to implement extended use if we don't have enough supply. From what I'm hearing, some folks are really good, have a good supply of N95 now, N95 masks now. It's the surgical masks that a lot of folks are struggling with. All right, so I'm gonna hop right to the next slide here. If I can get it to move forward, there we go. All right, I'm gonna leave this up, but I will say, I wanna leave this up for you guys to read it. I'm not, this is not my area of expertise, but I do know that I want to make it clear that you guys understand that there is a process, just like there's a process to request PPE, there's a process to request staffing resources, and it's done through the same form. There's that resource request form that is available on our website. We could email it out to you. It goes to the County of Mohawk, and on that there are sections to ask for staffing. I know that CDPH is doing those daily calls, and they're asking you for immediate or acute staffing needs to prevent you from evacuating. And those are great, but we don't know where those state resources would be if you had an acute need. And if that happens, we can't rely on that to be our source of emergency staffing. We have to understand that there's a process to request those resources from the county. And if the county can meet those needs, we can get them there quicker, or the county can get those resources, those staffing resources there a lot quicker than the state can. The state is working on a model where they would send teams of people qualified or at least familiar with skilled nursing care to be able to support those issues where you see a large outbreak in a facility causes 25 CNAs to test positive, and 40 or 50 of your staff are out. Those are the things that we want to be able to respond to quickly. We don't want to have a situation where you have to evacuate solely because you don't have staff for the building. So, but yes, I think as long as you submit those resource requests for staffing, I think that's your best chance for getting emergency staffing in there. Now, this assumes that you've already expired all your other internal resources like staff callback, switching to 12-hour staffing models, using registry to the extent you can get people to come in. We've heard a lot of talk, not every registry nurse wants to work in a COVID positive building. So that may be an issue you would address with the folks that you have as registry partners before you give them a call. Determine whether, if you have an outbreak, whether they'd be able to send staffing support. Find that out beforehand rather than wait till you have a desperate need to do it. All right, let's see here. Sorry, there's a slight delay when it moves from slide to slide here. All right. So I wanted to talk about mutual aid agreements. It has really come up in relation to how the facility in Tulare County was staffed after they had their large outbreak. So obviously they had a number of staff test positive that could no longer work, a number of staff out on suspicion of being positive. So they've got tons of staff out. What the county did was they contacted the hospital and said, unless you want these folks in your acute hospital, we need help from you to send staff. And so they had to develop a mutual aid agreement where the SNF would pay the acute to send staff. I don't know what the content of that agreement looks like, but I just want to broach that subject that we may be working jointly with the hospital association to develop a staffing mutual aid agreement so that in the future, if this happens, we have a set resource we might be able to tap into. And the hospitals are very interested in supporting that model because it would prevent them from having 80 or 60 or 40 people show up in their emergency room all at once. So that's kind of the mutual aid agreement we're working on globally. But that doesn't mean that you could not strike up an agreement with another skilled nursing facility or an acute to do any of those things. We actively encourage you to share resources, share, staff, maybe not so much because we don't want staff traveling from building to building, but when it comes to stuff, maybe you can have a mutual aid agreement with your partner down the street that has, 500 large N95s and you need 500 small N95s. There are a lot of opportunities here for us to pool our resources if we don't have access to any other supplies. I will say that we're under the assumption that the vendor networks are starting to be restored. The supply chain is flowing to some extent. It's not great, and there's not a lot of capacity in terms of supplies, but there are supplies that are flowing to folks. There's still acute needs for specific things. Gloves are really hard to come by for some folks. ABHR is really hard to come by for some folks. Surgical masks are really hard to come by. To the extent you can, you guys, as a part of the CMS requirements years ago, were required to build mutual aid agreements with your partners around your existing facility. Now is the time to utilize those, or to reach out to your mutual aid partners and ask them, if you have an acute need, if they have something that they can help you out with. I think the same goes to an acute. We don't have, and now acute hospital has, anytime you do a mutual aid agreement with them, they're going to want to have 16 lawyers look at it before they agree to it. But it can be something that's very basic, and we want, to the extent we can make it as simple as possible, we want to do that. And so, but I just want you to know that there are opportunities to collaborate with other partners out there through these mutual aid agreements that don't involve us trying to tap into a supply from a government entity that may not be responsive. And so if you're looking for examples of MOUs, we've got a number of them listed on our website. These are templates and drafts. They're meant to be customized, obviously, to your specific need. There's a number of them from other states that show examples from other states of how this works, but it's something that you guys can and should explore if you're hurting for supplies or for anything. I think we need to pool our resources, and that's probably the best avenue to do that. All right, so I know we've talked about all of these things that you have to do in terms of making your facility ready for COVID positive, and there's policies and procedures, and there's all these other things. We were approached by a healthcare system in Riverside County with a COVID care safety handbook that's designed specifically for the post-acute or long-term care congregate settings. So it's not just SNFs, but it's RCFBs and assisted living. The reason why I put it up here is because it essentially took almost every set of guidance documents that we've received from multiple entities and put it into one kind of handbook. Now, this is not really a policy and procedure, but it is a guidance document that collates everything. Now, this is Riverside County specific, so it has some Riverside County phone numbers in there to call for things like behavioral health or mental health needs, or helping healthcare worker hotline, things like that are Riverside specific. But the remainder of the document is very sound, and I advise you guys to take a look at it. I asked him for permission to edit it, because there are some things that I would like to add to it as a handbook. And once I do that, I will correct the link or this existing link and do that. Until that time, I don't have his permission to edit it, but I do have his permission to pass it out. So anybody, if you're interested, I highly recommend clicking on the link, downloading the PDF, take a look at it. Lots and lots of good stuff. Maybe stuff you're already doing. Most of it maybe stuff that you're already doing, just put into one resource, and then use it as a basis to determine whether your center is doing everything that you possibly can for the protection of these folks. All right, so I know I don't have a slide on this, but I wanted to briefly mention kind of what our suggestions are for record keeping. And this came up on a question or a conversation I had with a provider earlier this morning. I brought up a good point in that CDPH, when they release an AFL, they release it in a timeline format where we can go back in, and even now we can go back and we can download AFLs and guidances that they submitted back in February or March. And I know you guys, as a part of your record keeping, have done that. I just want to make you aware, though, that if you're using guidance documents from the CDC, as a basis for determining operational choices that you're making, those guidance documents have changed, and the old guidance documents cannot be found on the CDC website. So we're trying to recreate those documents so that you can have them for your records. But my suggestion is, if you've not already done this, anytime that you use a reference from a CDC document, my suggestion is to go back in and print that off in the version that it is now, because that version has changed repeatedly. Those links have changed repeatedly. So if you reference them in some way, shape, or fashion and have not printed that out, make sure that those are still accurate and try to print those off for your records. It's sad to say that there are liability exposures as it relates to this. We all hate to think of that kind of stuff when it comes to this, but there's a significant part of this that may be tied back to when you did certain things in a certain manner. And I want you guys to be protected and have copies of that, so that somewhere down the line, somebody can't say you weren't following the appropriate guidance at the appropriate time. So hopefully you guys have incorporated that and started to do that. And if you've not, my suggestion is to immediately start on that. And the second thing somebody asked us was, are facilities using incident command to manage these events? I know, we've done incident command training for years in nursing homes, but we've not had an event that was drawn out, that took a long time to manage, that had multiple moving pieces, that moved at a slow enough pace that we could learn as we go with incident command. And I've talked to a number of providers that say we run out of time, or we don't have time to respond to this, or we don't have time to respond to that. And I know that that we don't want you to try to learn this on the fly, but I think you may find some value that if you're operating this on incident command and you're delegating specific duties to people, I think you may find it easier that you're not replicating stuff that some of your other staff are doing. Now, that's my incident command soapbox. I would love to see everybody do it. I think the record keeping aspect of incident command will help us out capturing our financial costs. It will help us capturing those CDC guidance documents. It will protect us down the line, as well as help us manage the finite resources that we currently have in our building. And then lastly, I want to talk about the surveys from CDPH. Most of you guys, well, everybody should know that CDPH licensing is calling each and every long-term care facility in the state to assess staffing needs, PPE resources, a number of questions, and they've let us know that this is that they're going to do it. Unfortunately, they're not sharing this data with us. Our assumption is that they're going to share it with the local health departments to determine, like where the surge needs are greatest and who has acute staffing problems that they can send state resources to. We are actively trying to gather that information so that we can use it to help you guys in the counties that are most impacted kind of prepare. Once we get that information, obviously we'll use it and pass it out, and we'll share it on this call, not in terms of who's being impacted, but what areas of the state are most at risk. because we've all seen the numbers. The curve has flattened. The surge into hospitals is not as great as we had once thought. We know that most hospitals are operating at about 50% capacity, or somewhere between 50 and 60% capacity. So we know a lot of those things, and we can kind of help figure out where there's hospital surge, there's going to be skilled nursing surge. And so if we have that data, we can let you guys know, if you're in Riverside County, strap in. It's going to be a long ride. If you're in Orange County, maybe you're in a little better shape. Things like that. We'll be able to gather that information and tell you who's being impacted. The other thing is CDPH has said they're going to make this an online survey. And I know this represents an investment of time, but I really feel strongly that as a whole, I know it makes each one of us comfortable to give a regulator information that they could use as a basis for penalizing us after it. But for the greater good, it helps us in understanding where we can get resources to the quickest. And I like to believe that CDPH is altruistic in asking for those resources, and I hope that we use it as only that as a basis. I encourage you guys to do it, but I understand if you're hesitant to do it. But I promise you, it's not, or at least their goal is not to penalize you. It's really so we can avoid facilities like Riverside having to evacuate people, because it makes everybody in the nursing industry look bad. Every one of us, all our staff, our ownership, our leadership, everything. And it makes it seem like we don't value the folks in our buildings. And so that's the story that's being told about us in the press. And we want to be as helpful as we can during this time. I know being collaborative with regulators is difficult, but we've got to do the best we can in a given situation. So what do we see for the week coming? We know that in I'll say San Mateo, Santa Clara counties have really acute needs for post-acute beds for COVID positive people. We know that Alameda County and Contra Costa County are right behind them. Neither Alameda County, or at least Alameda County, does not have any alternate care sites or any SNFs that they have set up to take COVID positive people yet. And most of the remaining facilities in Santa Clara County are unwilling to take COVID positive people. So we have some really acute needs that you could see hit the news from those two counties specifically, unless we can figure out where to put these folks real soon. Los Angeles is already in that situation. There are a number of facilities in Los Angeles that are being supported with staffing from the county or from the state. The needs are pretty great in Los Angeles County. Riverside has gotten some relief in the opening of the COVID positive only skilled nursing facility in Moreno Valley. And I think once that fills up, we may see some other needs as well in that area. San Bernardino is a bit of a blind spot for us at this point. We know there's a number of facilities that have outbreaks. We don't know to what extent they're accepting COVID positive people back from the hospitals yet. Unfortunately, there's not a lot of capacity out there. So if we're sitting out there waiting for it to be our turn to raise our hand, now might be the time if you're in some of those counties that we've identified. In counties in the Central Valley area, we anticipate a little slower rollout. I'm not outside of Tulare, obviously, but Sacramento, Fresno, Modesto, the Stanislaus County, those areas in that region seem to be stable for now. And I think if we can get the Arco Arena site up and taking SNF positive people, that may act as a resource for the entire region. So we may incorporate Placer County and El Dorado County into being able to get some of those folks in there as well, Yolo County as well. So that's about all I have for what's happened this week, what's planning on happening. I do know there was an AFL that, I'm sorry, I was going to mention the AFL last night. I buried the lead. There was an AFL last night that essentially reworded the staffing waiver that got us all very concerned. And the language in the staffing waiver, if you've not read it, essentially says the only people that qualify for the staffing waiver are those being impacted directly by COVID. I've got the language here. Let's see. Or maybe I don't have the language. In any case, if you're directly impacted by that, then yes, you qualify for the staffing waiver. I'm going to get the language here. Give me 1 second. I don't want to give you the wrong language here. All right. So, yeah. So only those SNFs experiencing a COVID-19 related surge of patients or staffing shortages resulting from COVID-19 impacts, including but not limited to staff testing positive or presumed positive for COVID-19, may temporarily operate without meeting mandatory staffing ratios. Obviously, this does not factor in our high-risk staff that should not be coming to work, anybody that's above 65 or that has underlying health conditions. This doesn't take into effect that families or parents of children who no longer have childcare are impacted, or the fear of people not wanting to come to work, given the level of PPE that may be available at their individual facility. So it's a combination of a number of things that created a staffing problem before we even introduced COVID into the building. And one of our big pieces of advocacy will be to get that in writing and make sure that CDPH recognizes those shortcomings in the operations that you guys are currently experiencing. They have told us, verbally, that they're not going to look at this period of time when they do the staffing audits. And we've said, that's fine, go ahead and put that in writing and tell us that period of time then. Until that time, it's unfortunate. We'll have to ask Patty if we need to continue to submit individual waivers as a result of this, but at this point, I say stay tuned. Patty's taking the lead on determining how we get these program flexes and waivers from the state, and when that happens, we will post it on the forum and probably send out a magnet mail as well. All right, so that was the nasty part that we read last night. Courtney, do you have any questions on the question and answer sheet that we could jump to?
Hi there, yeah, and also we had a question about what was going on with the USNS Mercy ship down in Southern California.
Yes. Oh yeah, no, that's a great point, because earlier in this, well, at the end of last week, there was talk that the COVID or the Mercy ship was going to switch to taking COVID positive people, because that seemed to be where we had a need. We don't really have an acute need for hospital beds because the hospitals have nobody in them except for COVID folks. The USS Mercy ship decided that they were not going to take COVID positive SNF residents, but they would take COVID negative SNF residents. And we explained to them that nobody was going to voluntarily evacuate a nursing home resident to a ship because it did not represent a higher level of care. It represented a lower level of care. And if we were going to evacuate a non-COVID person, we would not have a problem finding space in other nursing homes for a tested non-COVID person, because we know they're not positive. So those Mercy ship beds for skilled nursing residents will probably only be used in the case where we have a situation like the facility in Riverside, where we have an acute staffing need where dozens or maybe even 100 people need to be evacuated out of a facility. That is about the only situation where I could see folks getting to the Mercy ship. The Mercy ship has a pretty stringent requirements for on admissions, and I'm not even certain we could qualify as a negative resident without going through multiple testing procedures. So it's a great idea in theory. It turns out we're not going to be able to use any of those beds. What we have talked to LA County, and LA County has advocated through the EMS agency to the federal government, is to use staff from the Mercy ship to support alternate care sites within the community. And they've already done that. So a number of those employees that were working on the ship are now working alternate care sites within the Southern California basin. I don't know the total number of hospital or medical staff that came off the shift to work in the community, but those resources are being used to support operations directly in healthcare facilities now. So I think that might be our only opportunity to utilize that resource. Certainly it's available to you, and on the LA County website, there's a transmission or admission guidance related documents. If you were thinking about, let's say you had an outbreak in a facility and you had 80 residents that were positive and you had 6 residents that were negative, and you could confirm that they were negative through the 2 serial tests, you could send those 6 folks to the Mercy ship or to another SNF and then turn your entire building into a COVID positive building for the remainder of the response. That is the only other slight kind of opportunity I see to use that space, but outside of that, I don't think it's a viable source for us to surge our patients to. Hopefully that explained it. All right, next question, Corey.
Okay, Rosie submitted a question. How can hospitals support SNFs in providing 2 negative test results prior to sending potential admissions?
Well, that's great. Unfortunately, I think the county local public health department gets to make the determination of whether they're going to use the test-based scenario to determine when somebody can be admitted into a SNF, or they use the non-test-based strategy. It's up to the public health department for that county or for that city to make that determination. But generally, like, I'll just give you an example. Like on the Mercy ship, if we want to send somebody there, the Mercy ship says, in order for that person to be considered negative, we need 2 tests drawn 48 hours apart. That's what they tell us. Now, I don't know of any public health departments that are currently requiring 2 negative tests for discharge to a SNF. Most of them are using the test-based or the non-test-based guidance, which is the 7 days after symptoms have first appeared and 3 days with no fever or 3 days no symptoms without the use of fever reducing medication. I think most of the counties are going by that guidance. The problem is the local public health departments are supposed to be working in conjunction with the skilled nursing facilities to determine their capacity to be able to take those residents. And what that means is the local public health departments, if they have the capacity, should be sending staff out to these facilities to double check to make sure the facility can do it, and that they have the appropriate PPE and they have the appropriate environmental controls and they have staff assigned to that so they don't cross-contaminate. All of those things need to be worked out, because if we don't, one mistake and it affects the rest of the building. So we have to do it in a thoughtful way. And at this point, I'm not sure that the local public health departments have the capacity to do that. And so if an acute care hospital has capacity to work in conjunction with the local health department to help a SNF, or to walk through a SNF that says, hey, I'm willing to help, I just don't know if I have the ability to do it. I want to do it in a safe manner. Can you come out and verify? I think that's a great way, and that's something that we're going to talk to the Hospital Association about at 3 o'clock this afternoon, is about what does that model look like of incorporating the expertise that an acute hospital has to manage these types of events, and have them come out in a non-threatening, collaborative way in conjunction with the local public health departments to do a physical inspection of the building. I feel very strongly that that we need to do this as a collaborative approach, and we can't be the only ones to bear the burden of all the legal liability for taking people into our buildings. We're not operating under any waiver of immunity. So when we look at things, we have to do it in a way that we feel is going to protect the other people in the building. And I feel pretty strongly that if you cannot maintain any of those things, it represents a real risk to the existing folks in our building. And so I understand if you say, look, I don't think I have the capacity to do this. My building's not set up to isolate a wing or a ward. I have a really hard time doing that now. That's a realistic concern. And the public health departments and the acute hospitals have to understand that if you're not ready and they send you folks, you're going to send them 60 people back. And then they're going to send all their staff to make sure that they stay in place. It's this repeating cycle that we see happen over and over and over again. Let's stop doing it that way. Let's do it in this method. And I know it takes time and I know it takes manpower, but nothing else matters. This is the most important thing that we will do. And we need any acute we have as a partner, any long-term local health department we have as a partner, let them know this is the #1 objective. We cannot compromise life safety of the people in the building. We just can't do it. And we feel very strongly about that. And if we can do it, we want you to say, yes, we agree that you have the capacity to do this. And that local public health department has to be the arbiter of how that happens. It can't be in a manner in which an acute or a health plan pressures you to take these residents if you don't feel you're capable of doing it. So I'll get off my soapbox. Next question, please.
Okay, Gonzalo has a question about the latest AFL. He says, I still read the latest AFL to mean that the waiver of specific regulatory guidelines to apply only if a SNF is willing to admit COVID patients.
Yeah, and this echoes my last point. I know it's the language essentially says you have to take them, but you have to take them in conjunction with your local public health department. And I'm giving you the roadmap of how you can do it. If you can't do it, you can't do it. You have to go, look, if you think I can do it, why don't you come here and show me how it can be done in my physical plan? I want you to show me with my staffing model how it can be done. I don't think I'm going to have the staff to do it because I'm going to have to share staff, and those staff are going to cross-contaminate the existing residents. So can you support me with staff to keep this completely separate? You can't? Oh, well, then I can't do it. We just go back and forth. And I promise you guys, there are hundreds, if not thousands of voices flooding the governor, flooding public health, flooding health and human services, flooding your local public health departments, telling people this represents a real risk to the people in your building. I think it can be done, and it is being done safely in other parts of the state. And there are currently partners throughout California that are currently doing it in a safe manner. But it really has to be thought out and planned for. And I feel strongly that you have to do it in conjunction with your local public health department. If your local public health department comes out and says, we're going to support your operations, and we feel like this is the safest way to do it, then I think at that point, it's up to you whether you do it or not. But you have to get that first before you even make your determination of whether you want to do this or not. I feel real strongly about making sure that somebody else that has a higher level of training and understands how this thing transmits to co-sign that you're capable of taking these folks. All right, next question, Courtney.
Sana wants to know, has CDPH considered having COVID patients in certain SNFs instead of spreading to all the facilities? This would stop the spread by staff,
Yeah,
therapists, etc.
yeah, and that's the whole point of having the alternate care site set up, because it would be nothing but skilled nursing residents that are COVID positive. So we wouldn't worry about transmission to other residents. It would only be for their care. The second thing we've tried to do is encourage large multi-chain providers to identify spaces that they could clear out. In other words, proactively evacuate a facility with that has existing non-COVID positive residents to turn it into a COVID positive only facility. Once again, that brings some really serious challenges with transfer trauma and all kinds of other issues with proactively moving folks that are otherwise healthy and safe. And then the third option is unfortunately the default option that that it almost seems like public health is doing. As outbreaks occur in skilled nursing facilities, those outbreak facilities would now turn into the COVID positive receiving centers. And to the extent they can continue operations. And unfortunately, I think that these facilities that have had these large outbreaks may find themselves in that exact scenario because we don't have capacity under the alternate care sites, and because there's so much risk in moving well patients when they don't need to be moved, exacerbates the problem. So I think until we can massively open alternate care sites, and when we talk about alternate care sites, think normally these are a government function. When we're talking about alternate care sites for SNFs, that means a SNF operator, administrator, a DON, a medical director need to be as a part of the alternate care site. And so we need a provider to provide those people to do it as an expansion of bed capacity in an existing facility. And all of the moving pieces that go with doing that, just imagine trying to create a skilled nursing facility out of whole cloth in a building that's never been designed to house healthcare patients. Everything that goes with that, it becomes a challenge. Dietary issues, linen, housekeeping, environmental services, infrastructure. The list goes on and on and on. So it takes weeks to set those up, and they're already behind the curve on this. So I think in the interim, we're going to see a lot more of these facilities having large outbreaks and then becoming COVID centers. And until that time, these folks are going to stack up in the hospitals because not a lot of facilities have capacity to safely take these people. All right, next question, Courtney, and we're getting close to the end. I want to kind of try to be cognizant of folks' time.
Okay, Michael sent in a question. Any news about hazard pay from federal, state for SNF staff?
Not as an add-on or anything like that that I'm aware of. I can ask Jeff Sandman. Jeff Sandman's the director of reimbursement, or Jennifer Breen, the assistant director. Either one of those, if you send an email, they can answer that question specifically. But I will say, as a best practice, we have talked to a number of owners and providers that have had addressed this already, or because of the staffing shortages, they've had to increase pay already just to keep people coming to work. And that may be exacerbated in certain parts of the state where COVID is more prevalent. But certainly we have asked for that, and that is one of the big asks. Doesn't mean that a provider couldn't independently do that. And we're working on a reimbursement model that's going to incorporate all of that stuff, an increase in pay, increase in cost of supply, because what an N95 mask used to cost 47 cents and now it costs $10. Things like that. All of those things we put into a package to ask for for money out of the federal funds and the state funds. All right, I think we got quite time for one more question, Courtney.
Okay, we have a question. Why can't patients be tested before being admitted or readmitted to a SNF after a stay in the acute hospital?
That's a good question. I think it's an access to the testing materials, and it's hasn't been the area of focus. It is now, and we have for the last couple of weeks we've been saying that we've told CDPH we want every admission and readmission tested that goes into a SNF, every single one of them. And then as a best practice on the provider side, we encourage you to treat every unknown person coming into your building as a suspect case. And so if you have the ability to have a transitional space where you can observe these folks for symptom development prior to incorporating them into the remainder of the building, we want to encourage you to do that. I don't want to mention a specific provider, but I know a provider group with a number of facilities that is doing that right now, and they've been doing that for a while. So if you've not thought about that, the talk of creating a COVID ward and all that stuff, if you have that space set up now and you're still not convinced you can take COVID positive people, but you want to take folks back into your building, have that transitional space where you can wait out to see if they have symptom development if they've not been tested. And then once they either don't develop symptoms for 14 days, then we can get them back in the remainder of the building, or if they do develop symptoms, obviously, then we get them tested. The other option is, keep them in that transitional space and have your own testing. There are plenty of private companies out there that will do testing at your facility. If your county does not have the capacity to test every admission and readmission, there's nothing stopping you from testing those folks. The problem is, what are you going to do when they test positive? So anticipate that some of these suspect cases are going to be positive. And what are you going to do with them once they are? Because you're not going to be able to transfer them out. So no hospital is going to take a non-acute person back. They're going to send them right back to you. At least in most counties, they're going to send them right back to you. So what are you going to do with that person when they're turning positive? Did you cohort that person with another person? Now the staff that were treating that person also need to be tested. So the testing should not be just limited to one. You got to kind of do one or all, or none or all, in order to get a true picture. And I do know that testing is covered under Medicare Part A, I think, or I'm not great on billing, but I know that it is a covered benefit. So so maybe we can get you guys some resources out, maybe we can post some resources on ordering your own testing in your building, and having a company come in and do that, or getting a lab contract to have somebody come do that. So, all right, folks, that's sorry I went over a little bit. Once again, CAF has all their coronavirus stuff. We update it daily. It's listed on that second to last link. And all of these videos will be recorded for posterity, and they are listed, or they're going to be on the CAF TV YouTube channel. Got tons of stuff on there. If you have questions as it relates to any of the response of COVID-19, email us at info@caf.org. I realize we get hundreds and hundreds of emails at that request site, but please be patient with us in our response, and we will get back to you as soon as possible. Thanks very much, everybody, and have a great weekend.